Look at us. Look at us. Here we are on the lounge. Welcome back, everybody. Thank you all for being here. We are the Critical Care Lounge. If you are new to the show, we are a medical educational program where we go over a variety of topics, but we do it a little bit special. I'll let my co-host, Dr. Adam Green, explain more. What's up, man?
Thanks, Kenny. How you doing?
Good.
So the idea behind this, I don't even know when it really originated. Probably during times where I was sitting, getting tons of phone calls from former fellows or colleagues from other parts of the world, and they're like, "What do you guys do for this?" And I realized there's so many things that we do every day that aren't described in textbooks, aren't necessarily obvious. And so we thought we should create a show that has live interaction. So this is like not us taping and making it perfectly scripted in our studio. This is happening as we speak, and have guests ask us questions and talk about what we've described as like the gray areas of medicine. Now, it's a lot of bread and butter. Like you'll see that today we're talking about pneumothorax, something we all see, but not just pneumothorax. Like, what do you really do when you're at the bedside and worried about a pneumo? And so that's the idea behind it.
Yeah, we talk really about the things that you don't find in textbooks, and that's really what we focus on. And so we're really happy that all of you out there are on today. Please send in the chat. We are very active in the chat. We want to know what your questions, comments are. Let's start off by talking about where you're coming from, what you do for work, and then we'll just give you shout outs as we go. But we're ignoring the most important part of the show today. Why don't you introduce our very special guest, Adam?
Sure. So this is Dr. Baldwin.
Hello. Nice to meet everyone. Excited to be here.
She is, where do I start? EMIM trained, did her fellowship at Cooper, and was our fellow of the year last year. Am I correct?
Yes. Thank you.
And what else? She won the March Madness tournament last year. That was an important
Inaugural.
thing. Yeah, inaugural. And I'm just really excited to talk about pneumothorax. Everyone knows that the pleural space is my favorite part of the body. And so I've been very anxious about this episode. Make sure we really bring it.
We did learn that during fellowship.
Yep.
It was always your topic for lectures.
So anyway, so let's get going, right? I think that's what
Let's
we
do
should
it.
do. So like we usually like to do, if we can, we start with the case. And big surprise, the diagnosis is pneumothorax. But let's get into it. And I think we've all seen this. So the case I'm thinking of is it's a 62-year-old gentleman, long-standing smoker, 50-pack year, comes in with, we'll say, pneumonia, is on the ventilator, his white count's coming down, is afebrile, is doing better. You're even thinking about extubating him, so you stop sedation, wakes up, he's coughing, and all of a sudden his oxygen status drops and becomes really hypoxic. And his airway pressures go up, and you're asked to come to the bedside. I guess just walk me through what your thought process is, a differential if there isn't even one, and
Sure.
how are you going to confirm it?
Sounds like a typical day in the ICU. So I think walking in first, right? You're looking at everything all together, right? I'm looking at the monitor. Are they tachycardic? Is he hypotensive now? Is he just becoming hypoxemic? I'm looking at the ventilator. I'm looking at my waveforms. What pressures am I getting? If I knew what they were before, hopefully I had some kind of baseline, right? I'm looking to make sure that all my tubing is connected on the ventilator. Did something come disconnected? Did something pop off? So I think first going in and examining everything as a whole picture.
Okay, so let's just do the given. It's a pneumothorax. So on physical exam, we read about a lot of different findings. What are the ones we see? So like, obviously tachycardia, obviously hypoxia, but like things like crepitus, is this something we see frequently? Or you read about some trachea deviation and tension pneumothorax. Are there any other things you were thinking about?
Yeah, so I'm definitely looking for those things. I can say in my practice, I've actually never seen tracheal deviation. Definitely crepitus, getting your hands on the patient, feeling for crepitus. I'm looking, do they have JVD now that they didn't have them before? Using our stethoscopes, taking a listen. Do I have bilateral breath sound?
Perfect. Great. And the ventilator you mentioned, talk me through the difference for volume control, pressure control, doesn't matter. What do you see? Because I'm thinking after you go, I'm going to tell a little side story of a case where I got fooled and it seems so obvious now, but it wasn't obvious at the time.
So looking at both, right? So I think whether you're using volume control or pressure control. So on volume control, right, it's trying to give that same amount of volume each time. So I'm looking, so now are my peak and my plateau pressures much higher than what they were before? On pressure control, right, we're limiting how much pressure we can give each time. So now did my volumes go down?
Perfect. And volume control, it's a balloon that you're still giving the same amount of volume in. It's just smaller now.
Right.
So the pressure is a lot higher.
Exactly.
Versus in pressure control, you're giving the same amount of pressure, but there's a hole in it. And so the volume is much smaller, right? Or I guess I should say the balloon is smaller and the volume smaller, the same pressure. So the example I was giving, and Haley, I want to hear your thoughts too, is I had a young gentleman. He was on AV ECMO for ARDS, and his compliance was garbage. And he was much more hypoxic, and his tidal volume, what had been before 250 on pressure control, I think he was on 15/10, was now all of a sudden 100. And he was tachycardic and a little more intensive. And I just thought, oh, it's probably worse than compliance from ARDS. And of course, I got an x-ray and it was a pneumothorax, and I was fooled. And I think if he had been on volume control, I would have immediately seen that the airway pressures were really high. And my mind would have been like, oh, this is probably pneumo, even though the physiology is the same.
Yeah, those are always tough. And that's why I think we're all big fans. So you're not going to roll your eyes at me, but some people do when I say ultrasound, right? Anytime something changes on a patient in the ICU, I just have a very low threshold to bring the ultrasound machine over. I think this is just a sidebar, but I think it should even be the point that nurses would be able to, pneumothorax is one of those easy things. We have some cases actually that we'll show a little later on. But putting a probe on the chest immediately, just when you have such a drastic change in ventilation, is quite important. So I think that would be the first move that I would do for that person. But certainly switching over, getting some pressures, a good therapist, respiratory therapist would do that automatically. But that would be done right away. I just need some numbers. If I don't have the ultrasound or I don't have an X-ray.
Tell me about the ultrasound then. What are you looking at?
Definitely the easiest thing to do, right? It's right there at the bedside for you, whether you're calling for an X-ray and waiting in that meantime. I'm pulling the ultrasound over, just like Heaney said, taking a look. You want to know what your normal looks like, right? So you're looking for your bat sign. You have your 2 rib markings with your pleura in between. I'm looking first for, do I have lung sliding? My next step usually is to then put M mode on it.
Let's talk about lung sliding, right?
So on lung sliding, right? So almost everyone wants to describe it as little ants walking, right? So you see the pleura moving.
We have a couple examples here.
There we go. Why don't you go ahead and say that again? Sorry, unfortunately it was muted. So Caitlin, can you just walk us through that again? What we're seeing here on the screen, talk about the bat sign. So we see the rib and the rib. Unfortunately, I don't think I can do the indicator. Maybe I can. Look, a little rib and a rib. And then what's this bright line that we're seeing right here?
Yes, in the middle, we're seeing our pleura. And I was saying that a lot of people you'll hear often describe it as almost little ants walking along, that shimmering going across, and you see that motion back and forth.
Yeah, that bright line, those are the 2 pleura sliding together, and you don't necessarily see anything, but what is that motion? And that motion essentially excludes pneumothorax at that point where you're putting the ultrasound. I think that's important to say because sometimes they'll put a probe somewhere on the chest, they'll find sliding and say, oh, there's no pneumothorax. And what you can reliably say is that is true. You can only see there's no pneumothorax at that point where you're putting the ultrasound probe. Anything else to add on that, Adam?
I think that's great. It says no pneumothorax, right?
Yes. So you're looking, even here, you'll often hear people speaking about seashore sign versus barcode sign. So it almost look like a sandy beach with water versus just a barcode going across, which again is showing you that there's no motion, again, at that specific point, making sure that you're looking at multiple different levels.
This is how a bunch of ER guys invented ultrasound. Different signs to use us.
The ultrasound folks, the ultrasound folks are interesting people. There's all sorts of signs. There's the algae sign. Anyway,
Plankton and everything.
People love to make stuff up. It's in the art.
That's cool. Even the most specific thing is if you can see lung point. And I don't want to get too much into thoracic ultrasound. We can talk all day about it, but I think it's important. And I think I've seen it, maybe 2 or 3 times.
Yeah,
so it's uncommon, but when you do,
take a picture of it.
Yeah, it's okay. Can't get it. But
yeah, I think even going back to some of the other videos we also had.
Here we go. I got it for you.
Oh, there you go. Great lung point.
Here we go. Lung sliding. So that's the transition point from where the pleura is approximated and there's no pneumo to where the pleura is not approximated and there is a pneumo. And that's the whole concept of sliding is, right? There's no air in the pleural space, therefore the visceral and parotid pleura are approximated and they're moving against each other. You can see. The second you introduce air, it blocks ultrasound and you can't see. And there's other things you'll read about like lung pulse, which is cardiac pulsations going through up to the pleura. So you will see sometimes a fixed pleura. They're not moving, but you see that pulsation.
Right, coming from the heart. Yep.
If there was air there, you wouldn't be able to see that pulsation. And
Yeah.
so,
And let us know in the comments if you've seen some of these signs or if there's another sign another term that you've used to call these signs. I'm interested to see what people are saying. But please let us know if you've seen these signs before. And the one thing I want to mention is that lung point can be really good if you know someone has a pneumothorax, but also to measure the size of it, right? So you can actually follow someone along your therapy. So you see your lung point that's like out here, anterior lateral line, you put them on oxygen, you decide not to do a procedure, which we'll talk about. But they start to now, their lung point starts to move a little bit more anteriorly, telling you that their pneumothorax is actually resolving. You don't have to necessarily get a x-ray every 2 to 4 hours or 6 hours or whatever, right? Yeah.
it blew my mind doing that.
Yeah. Sometimes I'll
Smart
actually take a
work.
Sharpie marker or a surgical
Okay.
marker and
That's
actually
cool.
mark it on the chest just with.
That was
I
awesome.
like that.
So where do we go next? So we talked about ultrasound. How about chest x-ray? Like, when are you waiting for your chest x-ray and when are you just to decompress?
Yeah, I think I'm calling for an X-ray, right? While we're getting everything else in motion, right? If they're what we want to see stable, right? He may be slightly hypoxic, but not crashing at that point. His blood pressure is still okay. Again, using our ultrasound, but I may wait for an X-ray at that point, right? And if I'm also not having any kind of confirmatory signs on any of my ultrasound, right? So we talked about lung sliding and lung pulse, right? So if I don't see a lung pulse and say this person's already intubated, there's other things that can be confusing and almost mimickers these. So at that time, I may wait for my X-ray.
Perfect. What are those? So what are the ones that, and trust me, if you look for these, you're going to find out where you don't see lung sliding, but the answer is not thorax.
Exactly.
So what are some of them that
Yeah. So I can definitely say I've had the right main stem intubation. I've had blebs mimic those.
yeah, so like big COPD blebs
Yeah.
for sure,
Exactly.
or ARDS. I've seen like in the later stages of fibrotic ARDS where you put it on and they're just,
Looks like nothing.
those,
Yeah,
those
not
lungs
moving.
aren't moving and they're
Yep.
stiff and they're stiff. Yeah. Pleurodesis is another one.
Yep.
Where someone's had a pleurodesis, they don't have a pleural space, pleural lines can't approximate, or they are stuck together, they're not moving, right?
Exactly. Yeah. So those I'm certainly waiting for my X-ray to again help in my diagnosis using more data.
I want to show you something. There's just someone, Adam will appreciate this. Randy's here.
Oh, good.
And he said, I saw the sign. It opened up my eyes. He saw the sign. Anyway, sorry. Keep going.
Oh, it just distracts me.
I know. And then like we should save his
Just
comments for
throw
the
it on.
end.
Yeah.
We should save, but he is like the third member of the team.
Yeah, he
you know.
So I'm going to take a pause and tell you why I love the pleural space. Have you guys ever seen a patient who's had bilateral pleurodesis? I have. And they're not dysmic all the time. And it makes me think, why do we even have a pleural space? And then I go on this long
A spiral.
spiral.
Do you have any hobbies that you'd like to do? Anything on your free time?
This is it, right?
We should find you.
You're seeing it.
We should find you something to do. But we all have our things that we like, and good on you.
All right, cool. Let's move on. This is a theme too, where I make fun of myself and then Amy feeds into
I just
I said it seems
Yeah.
easy. Pick on Adam.
and you can help yourself.
Yeah, that's right.
Help yourself pick on that.
That's part of the reason we're here. Great. So we did that. Now, I guess we should talk about intervening. The patient's crashing. You're like, all right, I got to put a tube in. The patient's not crashing. You're like, let's get a chest x-ray and make sure we're not missing something and don't necessary procedure. It's definitely cool. And we should even say that people with thoraces that are, I think you mentioned it, Annie, and no therapy is still a therapy. Observation is still a treatment.
Hardest treatment, but it's treatment.
Yeah, it can definitely. So what's your approach? Which size tube? What procedure? Percutaneous, surgical, pigtail, or do you like straight pneumothorax catheters? What do you think?
Yeah. So I'm, again, assuming that I have time. The patient is somewhat stable, right? My go-to is usually a pigtail. I like the anterior approach. Clavicular, second intercostal is usually where I aim for. So I'll usually try that first.
Okay, good. And this is, I think it's interesting too. A couple things is that midclavicular is always more lateral than you think. And second intercostal is usually more anterior than you think. And so I frequently see tubes being in too medial, too low, and too deep.
Yep.
It's also a procedure that, dare I say it, is not even ultrasound marked. You know your landmarks and you go. It's different than a pigtail I put in for a pleural effusion, in which case I'm finding the best pocket and I'm marking it and doing it. But let's say you don't want to do anterior because you've got a big fungating breast mass or something.
Yeah.
And you decide to go lateral. Where do you do it lateral?
Yep. So lateral, I'm looking at their kind of anterior mid-axillary line, and I'm going fourth intercostal, right? And we're always looking to go right above the rib versus under to avoid the neurovascular bundle.
Perfect. And probably better to go a little bit higher than a little bit lower.
Exactly.
You
Yeah.
don't want to all the things there.
And again, it's for pneumothorax, right? So air rises. So we're always going to go a little bit higher for these versus, again, if it's pleural effusion.
Annie, you agree? Always pigtail, anterior.
Yeah. It used to be that you would do all large bore test tubes, and then you'd do a smaller bore surgical chest tube or an open chest tube, and then the data started coming out. Pigtails are good just for air. And then for empyemas, it looked okay. And now even trauma literature, which used to be the last step in terms of putting in surgical chest tube, says that pigtails might be okay. And that comes from their pediatric literature where they used to put pigtails, where they do put pigtails in pediatric patients. And someone came along and said, adults and kids have the same size red blood cells. Why are we putting in big tubes into adults? And Kenji Inaba from LA County has done a lot of work on this, showing that it's not inferior to doing surgical chest tubes. So from just a humanism point of view, and I don't want to say a safety point of view, because some would argue that doing an open chest tube is actually safer. You make the cut, you can fill the lung, clear the space out. I think from a patient comfort point of view, if you've ever seen an open chest tube, they're just tremendously painful, and the screams, and it's hard to anesthetize or sedate. Doing a pigtail is way easier for people. And then you can always upgrade if you find a situation where the pigtail's not cutting it. I know we're talking about pneumothorax here, so that pigtails, pneumothorax should always be the way. But for other effusions, you can always upgrade it after that. It's my 2 cents.
Okay. What's next now? I guess chest tube's in. They're doing great. The nurse says, what do I do with this pleurovac? The respirator therapist says, what do I do with the vent? Like,
Yep.
What are the other things you're thinking?
Yeah. So it's in, you get your Russian air, you're connecting everything. So I think it depends on the situation. So again, if I have someone who was more stable when I first put it in, but we had to address this pneumothorax, I tend to put it suction. We're always looking at making sure, again, our pleurovac set up to -20 centimeters of water, right? So my first go-to will be suction. I'll reassess them throughout the day. If they don't have an air leak, I may then just keep them to water seal. If they were an unstable, say it was a tension pneumothorax, then I'm going to automatically put them to suction.
Okay. Yeah, I think that's great. And I think that's probably what like 90% do. I try to always do water seal and almost never do suction to a pneumo. And it's partly not based on science, but I just feel like I think that the negative pressure on a inflamed disease pleura is what causes fistulas and more disease. I actually don't even think in like thoracentesis, when you're putting the needle into a big pocket and you have pneumo, I don't think it's the needle. I think it's the negative pressure from removing the fluid. And so I'm just really conscious how I'm treating that pleura post-procedure. So I almost always do water seal unless they're trying to die, and then I do suction.
Right. Look at you, man. You're so sensitive to the pleural burden. Just so
Just
kind.
babying up pleura.
Yeah. You're okay. What you're saying, I think from a safety point of view, just equalizing the pressure, the buildup between the atmosphere will get you there, right? The patient will get better from there, and then the patient can resorb the rest on their own. I think that's perfectly fine. But it'd be interesting to see if there's actually a study that shows. I know theoretically what you're saying makes plenty of sense, but are there any studies that show that it increases the incidence?
Yeah, I don't know. Because I should say, like, when I put a chest tube in for a pleural effusion, I always start with suction. So that to me is different because you're going to hit a point where there's still
Right.
fluid and and the pressures are equal.
Sure.
Yeah, I don't know if there is a study. It would be interesting.
Yeah, we should go on the
Let's
fellows.
say,
Yeah,
do that
right.
next.
Yeah, no, get the fellows to do this study.
Yeah.
Isn't that what all smooth attendings do? So, yeah, you should do a study on
Yeah,
that.
yeah.
Just said, yeah.
Poor fellow who asked the question, just looking for the answer. Stuck with research protocol.
Yeah.
Yeah.
I think biggest thing, making sure that you're never attaching it to the wall. I think it's huge. I've seen
Yeah.
that.
Oh, really?
Yeah.
Oh,
It's well heard of it, but yes,
that poor pleura.
that really ruined your pleura.
Yeah, that's right. Okay, so how about the vent? There are a lot of things out there like minimizing PEEP. And I always worry PEEP 0 leads to atelectasis, which then creates more problems to begin with, or the FiO2 of 100%. What's your approach?
Yeah. Again, I think if they have a very large leak and then I'm concerned say it was in the scenario of someone who had PJP pneumonia, and I
Uh-huh.
think they may have a bronchopleural fistula, then at that time I may lower the peak to 0, but I'm not routinely lowering my peak
That's
to
interesting.
0 on a kind of typical
That's
practice.
interesting. That makes sense. Yeah, I've never thought of it that way, but that makes sense. And I don't believe in that percent of it too.
Same.
Got more. Annie, you good with that? All right. So now what do we? Tubes in, everything's going great, and I guess we should do some. Are there any questions we should
Question
address, or I
or
think
complication.
I was going to come up with a couple. We had a couple just cases of troubleshooting.
There was one question. I think it's a good time to address it now. I'll put them on the screen, give them a shout out. They're saying any tips for obese patients.
That
Sure. I think that also is even great when we were talking about that earlier, right? So our approach to where we're putting our chest tube, whether we're needle decompressing or doing a typical chest tube, you can sometimes have a little more difficulty going anterior, going through more tissue. Sometimes those are the patients that you may go straight to a surgical just because you can't get to that depth with your needle. So I may try, but I've had that situation where I've had to switch right over to a surgical chest tube.
Any tips for a surgical chest? Oh, I'll let you go, Adam.
so first I measure my distance,
Mhm.
so I know the distance between where the pleura is and the chest wall with ultrasound.
Yep.
So I know how deep I'm going. I know my anatomy, and when I commit it, which means that I will get the bigger needle if I have to,
Yep.
the one that's meant for the lateral, and I will go down. And I very frequently, this is a little nuanced, but I've seen people who use the anesthesia needle, decompress it, and then when they try to take the big finder needle, it's gone.
Yeah.
So I actually put my lidocaine in my big
Yeah.
finder needle,
Yeah.
and it's one stick procedure. And I anesthetize at the skin a ton and at the pleura a ton. And as soon as I get air leak, I go a little bit deeper, and then I hold it. Because I've also seen, as you're trying to get the wire, it
Yeah.
decomposes the whole thing, and then you can't get the wire in. But yeah, I think
That has
sometimes
happened.
lateral is easier, and sometimes you got to go surgical. Which case, obviously, always lateral.
Yeah, and for obese patients, go ahead.
Oh, no, I was saying that has also happened to me. As soon, even no matter how quick and efficient you are doing it, I've had to actually take the syringe and almost give a few cc's of air back to give yourself a little space to get the
Yeah.
wire back in.
Yeah. A thing like the 60cc syringe. Huge amount as you.
Exactly.
Yeah. Now, that's not to say that open chest tubes are not easy in obese patients. There are a couple tips and tricks that I've found using a bougie. Because for those of you who don't know, when you're doing a surgical chest tube, the key of the procedure is to keep your finger in the space. And if you're talking about someone skinny and you accidentally pull out, it's okay to find that hole again through the intercostal muscle. But if you're talking about somebody who's obese and your hand is really in there, your finger's in there, you take that finger out, you've lost that space, you're almost certainly going to be making another cut again. So you always want to keep a finger in the hole. Putting a bougie in place is actually a really neat trick that I found, because sometimes you do need to get out and get your clamps before you go back in there and to open things up. So that's just my 2 cents on that. Something easy, simple to do.
All right, let's do cases. So I'm thinking of things that happen all the time. So where do we start? So a patient has a chest tube in, space has been decompressed, you're happy, you go home, the nighttime team comes on, they're called emergently to the bedside, and the airway pressures are up, toxic, and let's just say they put the ultrasound on, there's no lung sliding. What are your thoughts? What are the first things you do? And we're not going to go into the realm of another diagnosis, because
Right.
if you say
We're sticking
PE,
to-
you say PE, then I'm going to lose my mind. So what are your thoughts in regards to this?
Yeah, so I think it's very similar to when you even just have a patient on the ventilator who's hypoxic, right? One of the first things I'm doing, again, is running all my tubing, right? We're in the ICU. These rooms are often small. There's machines everywhere. So I'm looking at the chest tube, making sure it's still connected. Do I have an air leak? Do I not have an air leak, right? The ventilator, did my CRT machine, something roll over by tubing. So now it's kinked and I'm not getting air out.
Yeah, looking at the titling
Mhm.
is so important, because then the negative pressure of the lung is expanding and deflating, it tells you that you're in the right spot. Now, there's times where your chest tube is up against pleura and you're in the right spot, but there's no titling. So I'm not saying that the absence of titling doesn't. Okay, great. Yeah. And there's so many times where the stopcock's turned and you literally walk
Something's
in
too
and you
full.
go like this, and then there's air and you're like, you're a hero. But that's really good. And then how about, is there ever a time when you flush it? Is there sometimes, you know what I'm saying?
Yeah,
In
definitely
the tube
had it.
itself?
Yep.
And how do you do that? Because I think I say flush it, and then I bet you some people will be, okay, that makes sense, but they don't know actually how to do it.
Yeah, so I'm looking to see if you want to change the stopcock, right? So I'm going to get a sterile flush. We're going to make sure we're cleaning everything. And then I'm actually flushing into the pleura, right? So you're blocking the air and everything coming back towards your pleura back. And then I'm going to flush forward. And then sometimes I'll actually try to suck that back out, and you'll get fibrin strands. You'll get some debris that's now blocked in. And all of a sudden you're getting an air leak again, and we're no longer hypoxic. Then making sure you're turning your the appropriate direction.
Yeah. And you'll feel it like as you go push the flush, you'll feel that pressure and it gives and you're like, oh,
Yeah,
so you
there's something
know.
there.
Yeah, that's great. Okay. So that was the first case I was thinking of. The second scenario I've seen is that similarly, you're happy with chest tube. You are night team's called into the room and they're acutely hypoxic. They're losing a whole bunch of tidal volume on the vent. 400's going in and 100 is coming out. And there is a crazy air leak going on. What are your thoughts there? And of course, the lung is down. Ultrasound.
So at that time, I'm again looking at my entire tubing, making sure it's connected. And then often you'll find out our patients get bathed, they get moved all the time, and these fortunately get pulled out. So I'm looking to make sure that are one of my eyelets now out of the patient. Sometimes you can try to adjust it, and sometimes you're fortunately may have to put a new one in.
Yeah, I struggle with what to do. I
Mhm.
honestly usually just try to shove it in. If it's safe,
Mhm.
then I try to push it in. Very frequently, the pigtail, because it's pigtail, you just can't.
Yeah.
And like really all you can do frequently is just take the tube out with another kit. And sometimes I even go through the same hole, try to minimize.
Yeah. Are you ever worried about infection if it's been out for a while? Pushing it in a little further?
Yeah, of course. But
Yeah.
I don't know if re-sterilizing and doing the procedure is necessarily better. But yeah.
Yeah, I know it's one of those things that if it was put in recently and you're not getting that, then it'd probably be okay. I'd be a little reluctant to put it in there for a day or two or a couple days. Just now you have it, since you love the pleura so much. I don't
It depends. The premise of the case too is that they're like acutely decompensating. And so of course, if I get the morning chest x-ray and I see half of it's hanging out, I'm going to take that thing, place it.
Sure. Sure. Yeah. Yeah. I've done this before, and you can argue it's not the best thing going in a different rib space right next to it. And keeping that tube in, just because it's already in, it's doing maybe something not, but doing something, and then placing another tube in. That wouldn't be wrong either. And then once you have the new tube in place, it's well seated. You do find it's an eyelid issue or something else.
That's great. And then the third kind of scenario, which I guess a couple different caveats, but I'm trying to think of how to phrase it, is chest tube is in, you get an x-ray, the lung is still down, and you come to the room and the chest tube's in and the lung's down, and there's a vigorous air leak, and you're like, I'll just give it more. And there continues to be an air leak. And so I think you mentioned this before, and that's a diagnosis of endobronchial fistula, right?
Right.
Bronchopleural fistula, sorry. And so how do you approach these? Are there treatments you can do? And you said low PEEP, and I think that's absolutely correct. Are there other things you can do to fix these fistulas?
Yeah, I think my first step is making sure that I can lower their PEEP as much as possible and see, can I get a better seal? Can they heal? How much healing am I going to get, essentially? When we've done that for a day or two or given them an appropriate amount of time, then I may be involved in some of my other services, right? So things like endobronchial valves. If they're able to take a look and see where it's at and they're able to place one of those, may be helpful. Or do they need a Pleurodesis at that? Again, it's always how stable, unstable is the patient, but those are usually, I'm speaking with IP, I may be speaking with thoracics if they need one of those procedures.
Yes, and EBVs are very neat, right? It allows air to escape, come back in.
Yeah, could you just go through that? Because I think there's going to be some juniors on here who are interested in what that means, how it's placed. They sometimes hear that thrown around, but can either of you just walk?
Yeah, they're really cool to see placed. When they go in, they'll go with our bronchoscope and they'll actually plug off different areas, and they're watching the pleura back at that same time. So they're seeing, when do I lose that leak? When is my bubbling less, right? So if they get to a spot and then all of a sudden it stops, they know that's the section that they need to place the endobronchial valve. And it's cool to watch. Sometimes It can take a long time, but they're fun.
They put in all these little valves. And so air from the lungs can't go into the pleura, but pleura, if it wanted to, air could from the pleura.
You're not causing more of air is not accumulating.
Yep. And they stay in for a while, and then they ideally heal. Fistula heals, you pull it out. But I would say probably the ultimate low PEEP move is to extubate, right?
Right.
So that's always what I'm obsessing over. And
Yep.
honestly, some patients have fistulas and it is what it is and they won't heal. And sometimes there's thoracic surgery options. That's usually very challenging, doing things like, lobectomy or things. And I'd be interested in both your opinion. I've heard this idea of pleurodesis when you have fistulas and the lung is not. I've always assumed if the pleura is not approximated, put as much talc as I want in there, it's not going to do
Never gonna-
anything. See, but I've seen people do it and be proponent when the lung is down. I feel like the lung has to be up, right?
Yeah.
No, I would say that was my understanding. Yes.
Yeah. And I've called some surgeons who are really aggressive and will do like things that are, we always have those consultants in the pocket who like do the really rare cases. And the one thing that I've noticed in thoracic surgeons, they're like, yeah, the pleura just has to be closer. There's just no way it's going to work. And it makes sense physiologically.
It's great. And then how about the blood patch? Have you guys ever done that? Or is that like voodoo medicine that like my attendings from the 60s would do?
I have never done one.
I've never done one, but we have someone at our hospital who is trying to get that going and doing more. Even then, still, I think the pleura also has to be a little bit more approximated than just for a case that I can think of in recent months. The pleura was just so far off the chest that even a blood patch wasn't going to work.
Yeah.
So there needs to be a certain approximation.
It's causing some inflammation, having it almost exactly you're not causing enough inflammation to fill a
Yeah,
full
exactly.
space.
But the idea is really cool,
It
right?
is- it is
So you
really good.
basically take some of their own blood, you turn the stopcock off away from the patient, and then you infuse it through the chest tube, and you hope that it goes to where the fistula is and coagulates, heals.
Yep.
But yeah, I've never seen it be successful. But I always think it would be neat if it was. Also seems like a Band-Aid, and all Band-Aids fall off at some point, right?
I think there's higher risk of recurrence with blood patches than just with like talc.
I agree. Okay, but it's also the least invasive,
Right.
Which is why.
And all of these things that we're talking about, where you have a failure to heal or there are things still happening. In some of these cases, it's just because of the acute illness of the person, the malnutrition. You hope that these Band-Aids, as you said, which are going to fall off, that you can catch them up nutritionally, some more healing. That's the goal of all of this stuff, is just to make sure that you fix all the other underlying problems while this thing is healing up, or you're preventing the damage, no more re-expansion.
Yeah, and sometimes the answer is Heimlich valve, which is basically no pleurovac, but it's a one-way external valve that allows there to be a long-term chest tube in. But okay,
So there was one question that kind of goes on that. And someone was asking, how do we feel about just doing simple aspiration versus putting in a catheter for pneumothorax? An interesting question.
Yeah.
I'll leave it to you guys to have my thoughts.
Yeah, I feel like that's more of a emergency medicine
Sure,
question.
sure, yeah.
I think that's something that is more spoken about in the emergency room because again, it's right your admission versus trying to get home. I think for us in the ICU, that's not something that I'm doing because usually, again, they're more critical, right? I need something to be able to, I'm reassessing this patient over and over again. I think if I'm at that point, sticking a needle in someone to decompress, I'm putting a chest tube in.
Yes, number one, it matters if they're on positive pressure ventilation. So if they're on positive pressure ventilation, they get a long-term chest tube.
Yeah.
And I generally want them off the vent before I take the chest tube out, unless I think it's going to be a chronic vent. So that's number one. Number two, I'm more than fine with doing an aspiration of a simple pneumothorax, just like I'm more than fine with doing thoracentesis and pleural effusions, but you'll see that I never do. And part of it is honestly time constraint, laziness, whatever you want to call it, in that I don't want to take the time to do this decompression and then 4 hours later have to come back when I have a million other things to do the same procedure that I could have just done to start with. So I almost always will just put a chest tube in, and then if the pneumothorax resolves, I will clamp it the next day and then pull it 4 hours later.
Interesting. I would say the same answer as you, except I'm not going to call it laziness. Because to me, the biggest risk, whether you're doing a thoracentesis or a pigtail, is puncturing the pleura, right? Or actually, I should say injuring the lung, right? You're puncturing the pleura regardless. You're always taking the risk on of causing a pneumothorax. I would much rather leave in a pigtail in place so that if we get that little nick of the lung and we get a little pneumothorax, we've already taken the biggest risk. I would rather leave something, even if it is for 4 hours, right? Even if I do have someone who I'm going to be like, yeah, it's going to be short term, we're going to take it out. I'd rather leave that catheter in place, drain everything I can about a pleural effusion, Or if it's pneumothorax, get every little bit of air and then take it out. But to me, sticking a needle in, violating the pleura, risking a pneumothorax, only to leave some stuff behind, whether it's air or fluid, never made much sense to me. So pigtail to me doesn't mean it's going to be in for days. We can probably take it out in a couple of hours, but why just stand there with the needle? And you never get it, right? You're always standing there draining. The patient moves, you come out of the pleural space. I just feel like a pigtail always is the way to go.
I think that's fair. Okay, good. Now, how about if you have a patient, this is the kind of last, it's very similar to the last one, is that you have a patient, the chest tube is in, I'm telling you it's in, there's no issues with the chest tube, and the lung isn't up similarly, but there's no air leak. What's the diagnosis there? And this is honestly usually not for pneumothorax. I should say that this is usually the patient who's had a long-standing pleural effusion, and then you drain it, and so what's the diagnosis there?
Right. So we said the lung is not up, correct?
It's not up.
Everything else.
There is a pneumothorax.
Yeah. So I would be worried about trap.
Good. Absolutely. And that's just, the pleura is fixed, right? And doesn't want to expand. And so what do you do about that? Usually nothing, right?
Yeah. Those are tough cases.
Yeah. I don't know. Like, I think there's theoretically you can do VATS and you can do pleural stripping and there's things your surgeon can do. But for the most part, it's there. And when you take the chest tube out, fluid fills the empty space is what it is. But I think we need to at least mention it. But and that's actually the case you always see that is the pleural effusion that you decide to drain. And then you get the x-ray and the radiologist calls you. They're like, hey, Dr. Baldwin, there's a pneumothorax in room 14. And you're like, oh no, what did I do? And you go in and the guy's like eating a turkey sandwich and his SAT's 100%. You're like, wait a sec. Oh yeah. I didn't do anything. It's just, I just uncovered.
I emptied that space.
I just condensed.
Yep.
I think that's really, good. Now, I think the last thing to talk about is just how do you get the chest tubes out? What's your approach for that?
Yeah, so I know we discussed earlier whether the chest tube is on suction versus water seal, but obviously my next step, so say if it was just on water seal, right? I'm then going to clamp my chest tube. So you ever see that blue sliding piece that goes over the tube? We're going to make sure that, or we're going to see that air can no longer come out. Again, no air is going into the space, right? And then I'm repeating that x-ray in about 4 hours usually. Obviously sooner if there's any hemodynamic changes, but I will look on that x-ray and I'll make sure that there's no reaccumulation of my pneumothorax.
All right, pull the thing, right?
That comes out.
The one caveat I always say is be aware of what tube is in, because we always put the pigtails automatically pigtail when you take out the stylet.
Oh yeah.
But IR, we'll use those skaters frequently, which has a string they pull and tie. If you don't cut that string, then you're making a big hole and there's usually bleeding.
And uncomfortable for the patient.
Right? I actually cut every single chest tube, even if I put it in and I know, because I was like, there's going to be a string hiding from me somewhere, but I just don't want to risk it. That's good. And then does it matter? Is it okay if we talk, does your approach change if it's for a pleural effusion, specifically if it's transudative or exudative, or is there a different algorithm, or is it always water seal, clamp, 4 hours, pull? Like, how do you think for pleural effusion?
Yeah, definitely. In pneumothorax, you will get some kind of serous fluid coming out. Or that I'm not tracking how much fluid is coming out of there all the time. For an effusion, I'm looking to see is it slowing down? How much is coming out? And again, if it's transudative and I'm treating the underlying cause. So was it because they were in heart failure, right? And I had to remove that fluid because they were hypoxic, right? So as long as I've removed that fluid, I fix their hypoxia, right? I'm also treating their heart failure. So I'm trying to get that chest tube out faster. If it's exudative, it's a bit different.
Yeah, I think that's right. My approach would be for transudative effusion is treat the underlying cause. Because I've seen those hepatic hydrothoraxes where you leave the tube in and it's liters and liters and it's never going to stop. Yep. They're going to go into renal failure. They're going to go into shock. You just got to take the tube out and accept that there's fluid there. But if it's an exudative effusion, and let's say it's not like an empyema that needs to be drained, I don't know, maybe less than 300 every 24 hours is my mark. And then I usually clamp, wait the next day, and then just take it out if the chest x-ray looks okay.
I agree with that, making sure that it's just not refilling in their hypoxia again, just that not fill too fast.
Okay. That's usually. Anything else?
No, I think about transudative effusions, to be honest with you, most of the time. They're just to get the person re-expanded so that they can breathe better. That's first of all, after it's a transitive infusion, if you're not doing it diagnostically. But then after you re-expand them, I just want them to breathe again. And most of the time, just getting that massive amount of volume off of them and then first.
Taking off that load.
Exactly. Now they're able to re-expand, have breathing. They get off the ventilator or they just breathe easier. And then the exudative infusions, I'm much more aggressive about getting those because I'm clearing out whatever's there. I don't want it to become fibrinous and become either scarred, coagulated, and then obviously if it's infection for source control.
All right, so I think that's most of what we had. So I don't know if they're...
Yeah, let's go ahead and take some questions from the audience. So please drop your questions in. I'll scroll back, see if there's any we missed. Someone said us to define Robert Bowman, who's, by the way, always a loyal viewer of this and the other resuscitations. So thank you for being here, Robert. Actually, let me give Robert a full shout out. He's tuning in from Arkansas, work critical access ER, family medicine trained. And again, just always a very vocal part of our community. So thank you. He was asking to define trapped lung.
Yes, there are, if you look in the literature, there are two entities called entrapped lung and trapped lung. And I think it is too nuanced to matter. So I view it as, I think we're going to pull up an x-ray, is essentially when the visceral pleura does not, even though the space has been evacuated. So the definition, I don't know if you have more.
No, it sounds like a good definition. And what's your approach to that?
Yeah, I don't know. Usually it's treat the underlying process. So if it's a trapped lung from infection, treat the infection. Hope it expands. If trapped lung from malignancy, treat the malignancy. If it's otherwise, sometimes you will do a VATS and pleural stripping physically.
Yeah, I have to say, I think I don't go more than 2 chest tubes. I've seen people get multiple until they realize that this is just trapped lung. If your first one's in and there's some question about whether is there some other pocket I'm missing or was there something with the chest tube, I may try a second one, but I'm not putting multiple pigtails escalating to a surgical chest tube, right? It's clearly I'm not going to re-expand.
Which I think is probably the teaching point is that it's not the fact that the x-ray shows a pneumothorax, it's whether there's clinical consequence to the pneumothorax. So if there's air in the pleural space and there's no clinical consequence, you just take a second, maybe get a CAT scan and see what the pleura looks like. And you can look at that x-ray, right? Where all those arrows are, it looks thicker. Pleural line looks thicker. It's definitely more obvious than a lot of acute pneumothoraces that you see.
Another question is, I think we hit it, but let's just be deliberate. Mohammed Salmani says, what's your approach with conservative treatment for primary spontaneous pneumothorax? So this would be someone who's not on positive pressure ventilator. It could be in the emergency department, or maybe, I hate to say it, but maybe July 1st in the ICU, so it would be a procedure. So essentially it sounds like a pneumothorax this is primary, not secondary, but regardless, it's just one that's not so bad. The person's not symptomatic, but it's there on the x-ray. What would be your approach?
Yes, I think we even said before, it's hardest thing I think in medicine is to do nothing, right? So if their blood pressure is good and they're not hypoxic and it's small enough, right? So I may just watch it. I'll repeat the x-ray later in the day. I know we touched on earlier, you'll hear sometimes we'll do non-rebreather, 100% oxygen. How much does that really help? Probably not a lot, or can cause some other problems. So it's watching them and reassessing throughout the day.
Adam, what about you?
Yeah, I think hanging out and getting more chest x-rays and watching them clinically is okay.
Yeah, most of these just resolve. You just have to have the patience and clinical maturity to just wait. And sometimes it can be really hard. Yeah. You just want to do something, like you said. And I love this phrase. Just stand there, don't just do something. And that applies in emergency medicine and care. Yep. Yeah. First of all, just so you know, for those of you who are tuning in, we have been doing the show virtually for a very long time. And then last episode was our first live one. And you are our first live guest in the studio.
That is awesome. I am honored.
Yeah, I wish we had something to
come hang out with you guys.
We'll give you this big play.
Perfect.
There you go. That's
for my new home.
That's for being our first live guest.
Love it.
You get nothing out of it.
Yeah.
That's okay.
Forget it.
But we're going to be doing more of these episodes coming up. We'd really love to have you back on and talk something beyond thorax.
Yeah, I'd love to come back. This was awesome and great questions. It's fun.
With that, I think we should close up the show. Keelan, thanks again. Enjoy your fake play.